Every hemodialysis nurse wants to provide the best possible care for their patients. A big part of that care involves the assessment and cannulation of fistulas and grafts. These accesses are a patient's lifeline, so it is understandable that both the patient and the nurse can find this component of care very stressful. Improving your knowledge and skill of assessment and cannulation of fistulas and grafts can help to decrease both your and your patient's stress. We hope that by building your confidence in these areas, you will be able to positively impact your patient's dialysis experience. Throughout a patient's kidney disease journey, he or she may transition to and from different treatment modalities. Their experiences shape their knowledge and perspective of how they view their dialysis treatment. Giving patients the opportunity to provide input and help to plan for their care increases the likelihood of success. Ensure that you allow adequate time for you and your patient to discuss past successes and challenges with their fistula or graft. Hand washing is essential to providing safe patient care. You should always adhere to the 4 moments of hand hygiene. Wash your hands before initial contact with each patient. Wash your hands before any aseptic technique. Wash your hands after body fluid exposure risk. Wash your hands after any contact with a patient or environment. It is also important to ensure that patients wash their hands prior to the assessment of their access. Whenever possible, you should also encourage patients to wash their access arms. The use of appropriate physical assessment techniques can lead to early identification of causes for delayed maturation in fistula. Ideally, an AV fistula is mature and ready to cannulate using the rule of 6s. The fistula should be no more than 0.6 centimeters in depth, be at least 0.6 centimeters in diameter, have a minimum blood flow of 600 milliliters per minute, and be at least 6 centimeters in length. You should ask the following questions to help inform the status of the AV fistula. Have you noticed any changes in your AV fistula? For example, has there been any decrease in the thrill in your fistula? Have you experienced any pain, tenderness, or redness over the AV fistula since the last treatment? Have you experienced any discomfort in your hand on the same side as your AV fistula, such as numbness, tingling, change in sensation, loss of strength, swelling, discoloration, or pain? If the patient identifies any of these symptoms, it is important to have them elaborate. For example, if the patient states that he or she is experiencing pain, have them quantify the severity of the pain and describe how the pain impacts their daily activities. When assessing an AV fistula and AV graft, nurses must incorporate the look, listen, and feel principles into their assessment. The first step is to look at the AV fistula and AV graft. The nurse positions the patient's arm so that she can fully visualize the entire length of the AV fistula. If necessary, the nurse will ask the patient to roll up their sleeve to expose as much of their arm as possible. Remember, it is important to ensure that the patient has positioned himself in the chair so that they are comfortable for the duration of the assessment and ultimately for the entire length of the dialysis session. When observing the AV fistula, it's important to focus on the diameter and length of the vessel, the presence of any aneurysmal dilatations or pseudoaneurysms, any evidence of unhealed sites of cannulation or scabs, any loss of skin integrity, which may appear as shiny or thin areas over the AV fistula, and any evidence of scarring which appears as white patchy areas over the AV fistula at sites of previous cannulation. Through discussion with the patient and visual inspection of the fistula, it's important to note the most recent sites of cannulation and if the vessel is tortuous. Always remember to look at the patient's hand on the same side as their AV fistula for any evidence of Steele syndrome. Steele syndrome can be recognized by discoloration of the hand. The hand may appear dusky, have a bluish tinge, or is pale in color. Also look for any unhealed open areas or evidence of tissue ischemia on the hands or fingers. It is important to know that all of this information applies to the assessment of both AV fistulas and AV grafts. In addition, when assessing AV grafts, it is essential to look for the presence of any signs of infection, observing for any redness, erythema, or exposed graft material. Signs of inflammation or the presence of infection may appear as swelling over the graft and surrounding tissues. It is also important to inspect the hand and the entire arm for swelling that may be a sign of central vein stenosis. Third, look for crusted areas larger than a needle site. These areas should be noted and observed closely, as a loss of skin integrity can place the patient at risk of prolonged or spontaneous bleeding if the crusted area becomes dislodged. The second step is to listen to the AV fistula and AV graft. The nurse should use a stethoscope to listen to the entire length of AV fistula, starting from the arterial anastomosis to the end of the AV fistula. The nurse will then be able to hear an audible bruit, which is more pronounced over the arterial anastomosis. The bruit may be somewhat diminished along the course of the fistula, but should still be easily audible. Any change in the bruit should be noted because the presence of a high-pitched shrill may identify an area of significant stenosis. When listening to an AV graft, place the stethoscope over the entire length of the graft. The bruit should be audible throughout the course of graft. Any change in the bruit should be noted. The presence of a high-pitched shrill may identify an area of significant stenosis and should be reported to the patient's responsible nephrologist. Further investigations may be required, including measurement of excess blood flow. The third step is to feel the AV fistula and AV graft. The nurse palpates the entire length of the AV fistula and ensures that the fistula is of adequate depth and diameter to enable cannulation. It is important to define the wall of the vessel in order to ensure accurate placement of the needle, which should be in the center of the vessel. When assessing both loop and straight AV grafts, the thrill should be palpable throughout the entire course of the AV graft. This part of the assessment should also include examining the patient's hand to ensure there is no evidence of Steele syndrome. The nurse should assess capillary refill by pressing on the patient's fingertips and palpating the patient's hands, noting any variation in temperature or strength. It is important to ensure that the AV fistula hand is not any cooler or weaker than the other hand. Determining the presence of a radial pulse is a key component. If the radial pulse is absent or diminished, the nurse should ask the patient if there are any additional symptoms of Steele syndrome, including diminished strength, the presence of numbness, tingling, or the inability to perform daily activities. Ensure to ask the patient if they are experiencing pain in their access hand. The pain may be more pronounced at night or during dialysis. It's important to ask further questions, including frequency of occurrence, if their pain awakens them from sleep, and how they are managing their pain. Some examples of pain management may include the use of analgesics or comfort measures, including the patient trying to relieve discomfort in the hand by hanging their hand over the side of the bed and keeping their hand warm. If the patient reports significant pain, it is very important to notify the patient's responsible nephrologist. Further assessment by a vascular surgeon may be required. There are two cannulation techniques to be aware of: rope ladder cannulation technique and the buttonhole cannulation technique. Rope ladder cannulation technique is the recommended standard cannulation technique for most patients. This technique requires rotating the cannulation sites along as much of the total length of the access as possible. Changing cannulation sites gives the previous sites time to heal, helping to prevent aneurysms from forming. Ideally, the nurse should choose a site approximately 4 centimeters from the previous cannulation site. Buttonhole cannulation technique is ideally used for self-cannulation. This technique involves inserting a needle into the same spot at the same angle and at the same depth for every dialysis treatment. Here, the nurse is performing the rope ladder technique. The equipment is prepared based on a thorough review of the patient's chart, including prior assessment notes describing the outcomes of previous cannulation attempts. It is important to discuss the cannulation plan, including the intended sites of insertion of the arterial and venous needles, any changes in needle type or size, and cannulation of any new sites along the access. Engaging the patient in discussions about the cannulation plan helps to fully inform the patient of the process and provides the patient with an opportunity to give input. This may help to reduce any fear or anxiety that the patient may have. Hemodialysis needles are available in a variety of sizes, ranging from 14 to 17 gauge and from 15 millimeters to 25 millimeters in length. Longer needles are used to facilitate cannulation of deeper vessels and should always be used with caution, ensuring not to damage the back wall of the vessel during insertion. Teflon needles are another option and are more commonly used in AV fistulas. This needle, once positioned appropriately, leaves only a plastic cannula in place during the hemodialysis treatment. This may be a good option in patients with fragile vessels or who may be a bit restless during their hemodialysis treatment. When assessing an AV fistula or AV graft, remember to use the principles of look, listen, and feel before using the ultrasound technology. Introducing ultrasound technology into your unit for the assessment and cannulation of AV fistulas and grafts is another tool to help improve cannulation outcomes. Nurses can use ultrasound for the assessment of all new AV fistulas or grafts, and, when assessing more challenging AV accesses, having the ability to visualize the vessel can help the nurse feel more confident prior to cannulating. Apply ultrasound transmission gel over the entire length of the AV fistula. The gel acts as a lubricant that allows for easy movement of the ultrasound probe across the AV fistula and allows sound waves to be transmitted through the body. Reference your unit-specific infection control practices for use of ultrasound gel. Before using the bedside ultrasound equipment, ensure the equipment has been cleaned as per unit policy. Hold the probe so that a cross-sectional view of the AV fistula is observed on the screen. Ensure that you are holding the probe with the notch to the left side of the patient so that you can see where the notch is on the screen. Landmark by placing the probe over the AV fistula as close to the original incision line as possible. Then move the probe slowly up the AV fistula for a longitudinal assessment of its entire length. It can be challenging to align the green dots with the center of the AV fistula. By moving the probe slowly, you will be able to keep the guiding vertical line in the middle of the green dots, ensuring it is centered on the AV fistula. You can visualize all the structures that cross sideways, on top or below the AV fistula. Move the probe along the AV fistula to assess the depth and the various segments of the vessel. Each dot on the screen demonstrates a new structure. The ultrasound allows you to visualize changes in depth along the vessel. Turning the probes allows for a cross-sectional view of the vessel. This allows you to view various structures in the AV fistula, including the presence of a hematoma. By applying gentle pressure using the probe and then releasing over the axis, you can see that the fistula is patent and no visible clot is present. Switching between the cross-sectional and the longitudinal view allows for a comprehensive assessment of the axis that is needed for needle site selection. It is important to hold the probe as steady as possible when switching between views. Based on this assessment, you will determine the most appropriate sites to place the arterial and venous needles. The ultrasound allows for identification of structures that might inhibit cannulation, including the presence of valves, areas of stenosis or narrowing, the presence of hematomas, or vessel branches. Visualization of the entire length of the vein helps to ensure the needle can be accommodated within the vessel. Assessment of the depth of the vein provides the information required to determine the appropriate length of needle for use and to assess if cannulation is possible along the entire length of the vessel or if only small segments of the vessel can be used. Using the ultrasound screen to guide cannulation placement, the nurse inserts the needle at a 30-degree angle while holding the probe in her other hand. The nurse slowly inserts the needle and then removes the metal stylet, leaving the plastic cannula in place in the fistula. The nurse then closes the clamp and secures the needle as per unit policy. It is very important to ensure that the needle is adequately secured during the dialysis treatment in order to prevent it becoming dislodged. The needle is then flushed using 10 cc's of normal saline, observing the fistula for any signs of swelling and at the same time asking the patient if they are experiencing any discomfort or pain, which may be a sign that the needle has perforated the vessel wall during the insertion. Conversations with the patient need to be documented so nurses can be cognizant of past successes or challenges when cannulating an AV fistula or an AV graft. In order to help inform the patient's next treatment, the nurse can suggest helpful hints regarding the cannulation process so that the patient can share these with the nurse who is caring for them. Once the patient is connected to the hemodialysis machine, it is extremely important to remain with the patient and observe both the arterial and venous needle sites for any signs of swelling and/or pain or tenderness at the needle sites or anywhere along the axis, any discomfort in the hand once the patient is connected to the dialysis machine. If the nurse notices any evidence of swelling or the patient reports pain at a needle site, stop the dialysis and consider removing the needle from the affected site. If the needle requires removal, remove the needle as per unit protocol and then repeat the steps outlined for initial needle insertion. If the patient reports significant discomfort in their hand, the nurse can decrease the blood flow and assess if this provides relief of the pain. Comfort measures, such as warm towels applied to the hand, may also alleviate some discomfort. If this occurs, it is important to notify the patient's nephrologist, as the patient may need to be reassessed by a vascular surgeon. These symptoms may be the result of Steele syndrome. Once the patient is successfully connected to the dialysis machine, it is equally as important to ensure the patient is comfortable and that you have addressed all their concerns and questions about their cannulation. We can positively impact our patients' experience by taking the time to understand their cannulation needs and ensuring that we provide individualized care for each and every one of our patients. Cannulation is a challenge for many patients, but we can help make their experiences better by taking the time to look, listen, and feel, and doing it all with a smile.
We shouldn't think of the first cannulation as a procedure. It really needs to be thought of as a ceremony.
My dialysis experience has been positive. They do a great job. I've been blessed with a lot of good nursing staff, And I totally get that it's stressful from their point of view too.
They keep asking if you're feeling any pain, and they pay attention to your eyeballs, see if you're doing okay. They're very attentive, making sure that the needle's going the right places, and that I don't feel too much pain in the process.
Thanks for not only listening and watching this video, but thanks for all your caring and all you do and all your understanding and the stresses that you go through on a daily basis just to help patients on dialysis live a more happy, healthy life.